All right. Hi, Gail. Thanks for agreeing to be part of the podcast. As you know, we're going to discuss some of the aspects of intensive care practice in the context of a case study. I know that you've read the brief already, but just to set the scene with a quick overview, it's 10 p.m. and I'm responding as a single responder to a 30-year-old female whose complaint is shortness of breath. I arrive on scene to find the patient alone and unresponsive. They're bradycardic, hypotensive, cool and clammy, not able to speak. They've got poor breath sounds, but a slight wheeze heard on auscultation. There's limited air movement with a rest rate of 7, prolonged expiratory phase, poor effort and irregular rhythm. SATs are at 80%. Temperature is 36.7, blood sugar 7.8. She's got a salbutamol MDI in her hand and there's a nebulizer running in the house. The stretcher backup ambulance is 2 minutes away. So with regard to having a structured clinical approach, this is an example of where if you don't go looking for something, you won't find it. An unresponsive patient certainly isn't going to tell you. Another important aspect about having a structured approach means it should be repeatable, in that it should be a habit that you're able to repeat at all jobs that you go to, and obviously it should be tailored to the patient's presentation. Do you have an example of when you realised that you needed to come back to having a structured approach to a patient assessment, and how important do you think that is?
Oh, listen, I think it's really important particularly in emergency medicine, when we get kind of critical care, very injured or very sick patients through the door. You often cannot rely on history from the patient because they either can't talk to you or because of their illness or whatever else. And I think it's really important to have a structured approach because, like you say, if you don't go looking for something, you won't find it. And if you don't think about it, then it won't come into your differential. And that's how you miss things. And that's how you get sucked down an obvious rabbit hole and get that kind of tunnel vision on one diagnosis without thinking about alternatives. It's also a really good way to go back when you've got a perplexing case that you're just not quite sure what's going on. Having that structured approach is something for you to go back to just do a rally point and go, okay, I'm just going to go back to the start and see what we've got here. And it means that you can pick up things that you may have missed the first time round. So it's definitely really important.
Perfect. All right. So let's take a structured approach to some of the key elements of this job and let me know what you think. So we get no response from the patient. We determine the airway is clear, and then we look at the breathing and find some problems there. So everything about it is off: the rate, the rhythm, the effort. We bring out the stethoscope and find a slight expiratory wheeze amongst the poor effort, but sounds in each lung. So there's a low likelihood of tension pneumothorax being the cause of the poor perfusion status that we eventually find. I don't think we need a SATS probe at this point in time to work out that this patient is in trouble. The long expiratory phase is a classic gas trapping symptom, and we're going to have to do something about it at this point. I think if we move to BVM, it does tie us up until the crew get there, but it could potentially stop the patient going into cardiac arrest as they are profoundly hypoxic at this time. So knowing that the backup is only a couple of minutes away, do you think it's a reasonable step to go to BVM and start ventilating the patient? I'll go first. I think it is. What do you think?
Yeah, I mean, I think it's that age old of ABC, and when you've tried a problem with one, try not to move past it until you've fixed it or attempted to fix it. I mean, in reality, we do things simultaneously. So it's not as simple as we just look at the airway and then we look at the breathing and then we look at circulation. In reality, those things happen simultaneously. So whilst you're looking at someone's airway or breathing, you're feeling for a pulse. So you're actually getting a picture of what C's doing at the same time as well. But, you know, you've got to think about what is going to kill this patient the quickest. And obviously hypoxia is going to kill them the quickest. So yeah, you need to do what you can for that. So it certainly wouldn't be unreasonable when you know that someone's a couple of minutes away. If you can feel a pulse and you know that you've got a radial pulse or whatever you can feel, if you've got some circulation going on, the most likely cause that's going to cause them cardiovascular collapse is going to be hypoxia. So yeah, I don't think it would be unreasonable.
Brilliant. All right. One of the things I've identified about my own practice is that I do lack a structured approach and rely a lot on pattern recognition and type 1 thinking rather than relying on a sound structured approach to things. I think in 13 years that I've been doing this, I've come across a lot of different jobs and have always worked in metro. So, you know, there's always been plenty of support around, and I reckon I've managed to get away with it a lot. But when it comes to critically ill patients like this, that doesn't work so well. You really do need to come back to that structure and step your way through the assessment. And particularly when I'm considering a new way of working in the critical care space, because there's new things to consider, like leading inexperienced teams in skills and procedures that I'm still learning myself and may not recognise the patterns in the same way. So with our patient in this example, we have a problem with breathing, and we can't exit the primary survey now until this is fixed. And I'd ask you if you agree, but I think we covered it in that last point there.
Yeah.
All right, so let's talk a little bit more about patient assessment. All right, so yeah, you mentioned in there about the complete picture. So, forming a clinical impression, what else could we be thinking here? I mean, pre-hospitally, we're limited in regards to diagnostic tools, and best practice is normally to come up with more than one differential diagnosis. But here, the saying, if it walks like a duck, quacks like a duck, then it probably is a duck. And I feel like this is the case here with regard to my impression being asthma exacerbation. So we've assessed the patient and everything seems to be lining up that way. And the scene paints a picture in what we've described above, and you mentioned it too. The patient's now decompensating and has deteriorated into hypotension, to bradycardia, low oxygen saturations, and really sound like they're on the brink of cardiovascular collapse. So is there anything else that is worth exploring before we put a treatment plan into place?
Oh, look, I mean, I think you've got to deal with what you see, and you've got to treat what you see at the time. I mean, other things that would jump into my head that are kind of sitting there in the background as what ifs are, has she choked on something? Is this a foreign body that's causing this? And less likely things like, is it a PE? Has she had an allergic reaction to something? Is this, she's actually had a chest infection and now she's fallen off her perch? There's other things that would be kind of bouncing around in the back of my head, just there to keep me alert that there could be something else going on. Because I say, if you go down the rabbit hole too quickly, keep looking. Just because you find a stab wound on a patient in their abdomen doesn't mean there isn't one under their armpit. So you've got to keep looking, even when you find what you think is going on.
Cool. All right. Yeah, sounds great, and totally agree. Putting in place together a complete assessment of the patient is really important. I haven't seen an asthma patient like the one that's described in this case study here, so my experience in managing these patients is lacking somewhat, and I wonder if it's related to a couple of things. Firstly, the way that we manage asthma in Australia, with primary healthcare involvement with asthma action plans and inhaled corticosteroids. And secondly, I think not being able to breathe seems pretty scary. And so I think people get onto it fairly quickly with inhalers. I've seen a lot of sick diabetic patients, for example, due to that being a much slower, insidious onset, whereas acute breathlessness doesn't look like a fun time. How often have you been sent to retrieve this type of patient, Gail, and in extremis, and sort of what are your top tips, I suppose, for assessing them?
Oh, look, I've got asthma, so I know what it's like to have an asthma attack, and you're right, it's miserable. It's not fun. I think asthma is more prevalent in the Northern Hemisphere than it is here. Certainly since I moved to Australia, my asthma has not bothered me, which is great. But back home in Scotland, we saw a lot more asthmatics in extremis than I've seen here. I've maybe only dealt with a couple here. Mm-hmm. The ones that when I used to work for RFDS, the ones that we went to retrieve were generally pretty clapped out by the time we got there, because they were in rural, remote areas with nobody that was really familiar with how to treat them. They are probably some of the scariest patients you will ever have to deal with. And the thought of having to put an asthmatic to sleep to ventilate them is one that fills every emergency physician with just sheer horror and dread. It's just not a patient you want to have to go down that route with if you can at all avoid it, because they have zero reserve. And it's not just the tubing that's so difficult, but it's the trying to ventilate them afterwards. So they're incredibly emotionally, psychologically, and clinically overloading patients when you have to fly them for 5 or 6 hours.
Thank you. Let's move on to clinical leadership now. I think one of the most important ways to start scene management the right way is by introductions. So pre-hospital care is unique in that you can end up at scenes without knowing the people there and them not knowing you. And so introductions can ensure that people know who everyone is, and there is a right and wrong way to do it. And if you come off with an aggressive approach of I'm here to take over, you can put people off, you can put the team off. It's a fine line between a strong introduction and going too far. So have you ever faced a similar situation working pre-hospitally when you're working with a team who you don't know all that well, and how did you manage it?
It's something I'm really familiar with, and it's something that I'm very interested in, is that whole kind of being able to work with flash teams and get the best out of them. It's just kind of, as you've highlighted, it's part and parcel of working pre-hospital and retrieval. And, you know, sometimes I would go to a job, a particularly sick patient, you'd walk in and everyone would just disappear. It was like someone waved a magic wand and everyone just boom, out of the room, because they're just like, oh, you're here, and they disappear. And that's very hard to deal with, because people just see the cavalry's arrived and they just want to get as far away from that situation as possible. I think the important things in dealing with these kind of flash teams is, you're right, your introduction is everything. You're not there to take over, you're there to support. You need to appreciate that this patient has been this team's patient prior to you arriving, and you're there to add value to the situation, not necessarily to take over. So it's really important for a number of reasons that you do those introductions. It's also been shown that if you do that at the beginning, people are much more likely to speak up during that care episode if they have concerns or they've got ideas. If you've actually taken the time to let everyone introduce themselves and give their kind of skill level, it incorporates them into the group.
Good points. One aspect of leadership that I found tough initially was delegation of tasks. So the way we train and practice as paramedics really is that you adapt and overcome with the minimal resources that you have on scene. So usually that's done with just you and your partner and nobody else. So when you're with a patient that is critically unwell and requires a team management approach where things are run in parallel, you have no choice really but to delegate tasks. And in our example here, being on our own initially to start with means that you can't necessarily run things in parallel, as you've only got one pair of hands there. But once the backup crew arrives, it's important to have some things that could be delegated to the crew for actioning straight away. One of the things I'm thinking would be to have a quick look around the house for medications, including, paperwork like the asthma action plan, just to help give us some history that we can't necessarily get from the patient. Anything else you can think of that you would need to delegate sort of immediately to the crew when they arrive on scene?
Look, I think there's a multitude of things that need delegated for this patient. And I think that's why it's really important that you do that initial introduction, so you can find out people's skill level and what their strengths are, because you want to play to them to get the most out of your team.
I think one of the other things to consider here is that if I'm operating at an intensive care level, then there is a bit of a difference in terms of skill level and the ability to carry out certain procedures. So, for example, and we'll talk about RSI and intubation safety in more depth in the next section, but that certainly is a skill that ALS paramedics don't have. And so I think if we're going to go ahead with a procedure like that, with others who aren't trained and drilled in that skill set, we really need to ensure that we know our stuff and are able to delegate tasks in the planning and the checklist phase appropriately. And so just a little bit more on non-technical skills. This is an area, or partly an area of strength for me. I know that crews are happy to see me when I turn up at their jobs, and I know it because of the feedback that I get from crews on this. So I remember a situation where I swapped a shift with somebody, and the person working for me turned up to a patient that had an airway issue that needed to be sorted. And when I spoke to one of the ambulance crews afterwards who attended that job, they told me that they wished it had been me who turned up as the single responder rather than the person who filled my shift that day. And for me, that's the ultimate compliment, because I know at these scenes, it's not just the technical skills that are required, but also the non-technical skills of taking charge while maintaining a calm and coordinated scene. And I think the good thing about non-technical skills is that it's an important part about being a senior clinician, or whilst it's an important part, the skills are things that you can work at no matter what level of clinician you are. So you can refine them at the non-urgent jobs, so that when you attend these critically unwell patients, like the one in the case study, it isn't so unnatural to lead and take charge. Can I ask you, Gail, can you think of a time where you've had to become a bit short with a team member because they're either not following your lead or about to do something unsafe in regards to patient management? And how did you manage that? And did you follow up with the team leader or the team member afterwards?
So there's one job that comes to mind straight away, and it was when I was a registrar in training back in Scotland, and I actually had to kind of assert up the ladder, so to speak, because it was one of my consultants who was mismanaging a patient, is the only way I can think of to put it. And it's extremely difficult because if you look at the hierarchies in medicine, traditionally it's not been accepted that you speak out in terms of your boss. You do what you're told and you carry on. It was the kind of traditional way you were taught, that you wouldn't ever question their ability. And I found it incredibly stressful having to do that. And essentially, I just resorted back to having to use one of those graded assertiveness techniques in tackling it. And kind of, you start off softly suggesting something's not quite right. And then you just get a little more forceful until I eventually just had to state, you need to stop what you're doing. And I actually said that out loud in the resus. And it was only at that point where he stopped what he was doing and turned around and looked at me. And then you just kind of wanted the ground to swallow you up. And his response to that was to walk out of resus and leave me with the mess. So it did get dealt with afterwards. So I actually actively sought him out. Not that same day because emotions were too high. And we talked about it afterwards. And with time to reflect, it had been a highly emotive situation that he'd been dealing with. It was a young lad who'd been hit at speed by a car.
Let's talk a little bit more now on patient management and clinical decision making. So the first thing I want to talk about is intubation and intubation safety. There are a number of things to consider here, like distance to hospital, team composition and capability, patient safety factors, and my own ability to carry out the procedure safely. And it's hard to talk about those things independently because a lot of the elements are all intertwined and related. But if I start with the distance from hospital, I think if we're 5 minutes away from an appropriate emergency department, then for me, it's a no-brainer to put in place just an appropriate basic oxygenation and ventilation strategy with a BVM. So something like 4 to 6 breaths per minute and transport them to hospital for invasive management. Would you agree, Gail?
Yeah, if you're that close to hospital, the safer option for that patient is to be intubated in a controlled environment. They're not easy patients to intubate. So if you're close, yeah, you do the basics and do them well.
Great. All right. So if we're 45 minutes away from hospital, which can happen in and around Perth, where you and I live, I think you could justify a more invasive management strategy for this patient. And the consideration now is it safe to proceed down an RSI pathway with the team composition that we have? And just to recap that, it's just me as a single responding intensive care paramedic and 2 ALS qualified paramedics. So I know in WA we operate a model where the HEMS single operator CCPs do this, and clinically it's justified as the patient needs that intervention to ensure a good outcome and be transported safely. I guess what I'm asking here is it safe for everyone involved, particularly the patient, to perform such a risky procedure? Like we've said with the asthmatic patient, they're one of the scariest patients that you can go down this pathway with. With no backup and a long way from any help. I'll give some thoughts first. Having not had to make any decisions like this about this type of patient, it sounds like it's going to be tough to optimize them because most of their hypotension is due to high intrathoracic pressures. And whilst there is some insensible fluid loss in asthma patients through breathing, I think most of it here is through impaired venous return. So pre-oxygenating will be difficult given the long expiration time that these patients need. And in our example, the patient's breathing at 7 per minute and a GCS of 3, and that might impair our ability to denitrogenize and pre-oxygenate effectively. What do you think?
So these are patients that if you can at all avoid it, just not to intubate in the pre-hospital environment. There's a whole gamut of other things that you're not seeing with this patient. The likelihood is they're incredibly acidotic. And we know that if you go ahead and intubate a very acidotic patient without doing anything about that, the chances of them arresting is much higher. So there's a lot of considerations to take into place with this patient, and you've got to think about potential alternatives. I'll give you an example. When I used to work for RFDS, I got a call from Geraldton Hospital, and it wasn't for a retrieval, it was for advice about a patient. And it was exactly this kind of patient who'd been brought into the ED. She was moribund, she was an asthmatic, she was brought in blue, completely cyanosed, with a respiratory effort of less than 4 per minute. And the quick thinking doctor there actually recognised that intubation was risky and actually put her on non-invasive ventilation. Now, this is a controversial area in asthma when you look at the evidence for it, but he actually saved this lady's life. And within an hour, she was sitting up talking to him. And this was when he called me, because he was just like, what do I do now?
It would be particularly hard to maintain situational awareness if you are, the only person qualified to perform the airway management skills that are required, and particularly with an ALS crew, you're certainly going to have to, almost delegate the team leader role for that time. Where if you're elbow deep in somebody's larynx, to make sure that they've got an overview of what's happening with the patient, letting you know what the SATs are, and all that sort of stuff. All right, so after we've implemented a treatment plan, we have to evaluate it, and I think it would be easy to see if the patient crashes. This patient sounds pretty brittle and close to cardiac arrest. So you mentioned earlier in your example about flying a patient and looking at a hyper or an end-tidal CO2 reading that seems unnaturally high. I guess that's something that you would definitely have to accept in this patient. But aside from increasing oxygen saturations, if we're talking in the context of pre-hospital RSI, what would you consider to be successful?
No cardiac arrest on induction would be a success. I think as I say, there are patients that I would avoid at all costs doing a pre-hospital RSI on, because you really can't stabilize them physiologically to a safe level. There's going to be some instances where it's unavoidable, and you just have to stabilize them as best you can to limits that you are happy with, or as happy as you can be with it. Ideally, you don't want them to desaturate on induction. It's going to happen. There's no way to avoid it, but you want to get a first pass intubation as quickly as possible. So it's taking that time to prepare, so that your first attempt is your best attempt and it's successful. That's really your key to success with these patients. And then just being able to get any kind of oxygen into them. You're probably going to have to manually decompress their chest. You need to be constantly aware of the risks of tension pneumothoraces with these patients when you're giving them positive pressure ventilation. Success is getting that patient to the hospital alive. And they're not blue.
All right, I think that's all I had to chat about, Gail. So thanks very much for all of that.
No worries.